Center for Institutional Studies seminar series. Our first speaker for this season is Antonella Bancalari. We're very happy to have her here. She's from the University of St. Andrews in the United Kingdom. Antonella got her master's and PhD from London School of Economics, and her bachelor is from the Universidad del Pacífico, which is in Lima, Peru. Antonella does public economics, development, policy evaluation, a little bit of experiments, and behavioral economics. And today she's going to talk about coordination and the poor maintenance trap, an experiment in public infrastructure in India. Antonella, the floor is yours.
Thank you so much, Leonid, for the introduction. I'm not able to share my screen, so I think you have to
allow you. That's in Bernardo's hands.
Victoria.
And while we're taking care of that, let me please remind you our regular request to identify yourself in the chat column of this Zoom. Antonella, the custom here is that you will talk for about 45 minutes and then we'll have questions and answers. If people have questions in the course of your presentation, they usually can do it by using chat. And Bernardo is watching the chat, so keep an eye on this, please. And then we'll have a regular Q&A.
Yeah, we'll keep an eye to the chat, so just focus on the presentation. And if I see something, yes, I will let you know so you can answer the question.
Perfect, thank you. I also don't mind if you want to interrupt me for any clarification question. I'll be happy to stop and I go back and explain. So please feel free to interrupt me if needed. Can you see well the screen now?
Yes, please. Yeah, perfect. Everything is quite clear and loud.
Perfect. Okay, great. So as I was saying before, again, thank you very much for the invitation to present this paper, co-authored with Alex Arman from Nova School of Business and Economics and Britta Osberg, my colleague from the Institute for Fiscal Studies here in London in the UK. And well, yeah, I'm Antonella Bancalari, an assistant professor in economics at the University of St. Andrews. And I will present today this paper titled The Coordination and the Poor Maintenance Trap, an experiment on public infrastructure in India. So the motivation from this paper starts from the fact that poorly maintained public infrastructure is a common sight in low and middle income countries, especially in developing cities. And this condition characterizes the provision of a wide array of basic services, from unreliable electricity grids and overstrained transport networks to inadequate water and sanitation facilities. And the World Bank estimates that a $1.2 trillion could be saved by investing in more resilient infrastructure to avoid costly upgrades or abandoning obsolete facilities. And even though in the policy agenda, there's a bit of this discussion on the maintenance of infrastructure and try to avoid of infrastructure becoming obsolete, there's not much discussion in the literature. There's some evidence linking this poor quality of infrastructure to a coordination failure involving citizens, service providers, and governments. And essentially, what we call this in our paper is the poor maintenance trap that is causing this low quality public infrastructure. And it stems from the fact that there is pervasive free riding to use infrastructure, these different types of infrastructure. For example, micrometers in water connections not working well, and people not reporting actually how much they spend. Is difficult to measure that. Or for example, illegal electricity connections and people just free ride on some electricity network from the neighbor. And even those that are paying are not willing to pay the market price. And there's a very low willingness to pay for a public infrastructure, and surprisingly, for public infrastructure that can improve the disease environment, which is very important in low and middle income countries. And what happens with this pervasive free riding and low willingness to pay is that effective prices for these public services drop below the marginal cost of operation, which links to lower revenue, and then the provider having lower incentives to invest and improve the quality. And if anything, the quality over time decreases, and in turn, it essentially makes free riding more pervasive and lowering even more the willingness to pay for this public infrastructure and the services it provides. So essentially, it creates a vicious cycle. Now, why do we care about this poor maintenance trap? Is because the quality of basic services that stem from this public infrastructure have been recognized in the literature that they impact human capital accumulation, economic growth, and public health, which are different measurements of welfare. And this is very salient in slums, in areas that are overcrowded, and in many occasions, these are just informal settlements that are home to more than 1 billion people worldwide. Now, there's a very large literature on the returns to infrastructure. We know that there are social returns. We know that infrastructure is a key driver of economic growth and development, but we know very little about the maintenance and how to incentivize collective action to break this poor maintenance trap. And when I say collective action, I mean not only from the user side, but also in terms of the dynamics between the user and the provider. So what we do in this study is, in this paper, essentially, we study how supply and demand side constraints contribute to the quality of infrastructure in low and middle income countries by experimentally varying the incentives on both sides of the market. And the context in which we do that is of shared sanitation facilities in the slums of 2 big Indian cities. The key contribution of our paper is that we provide an economic analysis on the provider-user dynamics in the presence of severe coordination failure. And essentially, coordination failure in this context of shared sanitation facilities that are called community toilets, it's extremely visible. You can see who is free riding because the fee is paid when you enter the community toilet. And also, there are not very large monitoring mechanisms to prevent people from entering. It's essentially the provider that is collecting the fees there in the entrance. So it's an ideal setting to study a very visible coordination problem and a pervasive free riding. So the approach we take is a field experiment in which we track 110 facilities and 1,500 slum residents over 1 year. And we collect various novel behavioral measurements. We implemented this field experiment in partnership with city governments and a wide variety of NGOs. Now, the context of shared sanitation infrastructure is not only relevant because of the visibility of the free riding and the coordination problem, but also because improving sanitation infrastructure can generate significant social returns. Safe sanitation is widely regarded as one of the most cost-effective public health interventions. And sanitation has been linked to child health, mortality, human capital accumulation, and economic growth. Yet, 30% of the global population do not have access to basic sanitation. And in India, the amount is 40% of the total population do not have access to even basic sanitation. And even in urban areas, 28% of the population do not have access to these facilities. In this country, the poor sanitation environment alone has been estimated to cause 9% of the infant mortality and 6.4% of the annual GDP, which amounts to $53.8 billion in the form of essentially time wasted to collect water to use for hygienic purposes, or trips to the doctor, or days ill because of this unsafe sanitation environment. So a little bit more about the context of our study. As I said before, the shared sanitation infrastructure are known as community toilets. It's because these are, imagine public toilets that are available in Russia or that are available in any advanced country, but that are used only by the community. And these, the community toilets we study are those located in 2 big cities and overcrowded cities of Uttar Pradesh, one of the largest states in India. And the 2 cities are called Kanpur and Lucknow. They are fairly close to Delhi in the north of India. So you can see here the location. This is Uttar Pradesh, and Delhi is located around here, and then Lucknow and Kanpur are inside this state, which is one of, well, the state is the largest. There are 200 million only in that state people, so that's larger than a country. But well, Russia is also really large. What these community toilets are essentially gender-specific toilets with urinals and hygiene facilities. There's a sink, there's a shower, so it provides a whole range of services. It is owned by municipalities, but managed through public-private partnerships. And essentially, the way they are operated are a bit similar to micro enterprises, in which there is a single provider, which is called the community toilet caretaker, in charge of collecting the user's fees and enforcing the payment, supervise or directly clean and repair the facility, and work only on one city, which is ideal for us to be able to treat that caretaker. Oh, sorry. I wanted to go to the next slide. And well, some people may be wondering why we're not focusing on the private sanitation facilities, but the Swachh Bharat mission, which you asked, Modi's insignia policy, in the urban component of it, in terms of being able to end open defecation in India, which is such a big problem, is the fact that private toilets will only be able to serve 80% of the urban population, while 20% is planned to be catered by cities. So what we find at baseline is essentially that community toilets are stuck in a poor maintenance trap. They are dirty, stinky, and they have harmful bacteria in all facilities. We collected bacteria with swabs that we sent to the laboratory, so we have a very accurate idea of the health risk of these community toilets. And what we find also is exactly what I was mentioning in the introduction, is that there is rampant free riding and remarkably low willingness to pay. In the left-hand side figure, you will see the distribution of free riding at baseline. On the y-axis is the share of community toilets, and on the x-axis, the share of users free riding in the community toilet. And we can see that only in 22% of community toilets, there is no user free riding, but there is a large variation in the share of users that are free riding across the different community toilets. Now, on the right-hand side, you can see the distribution of willingness to pay. I'm going to explain a little bit more how we measure this in an incentivized manner. And what I'm showing here is.
Sorry, can I make a clarification question? How do you measure free riding in that graph?
Yeah, that's a good question. So I'm gonna get to a little bit more detail on the data collection soon, but I'm happy to explain right now the fact that we send observers for 1 hour at a random hour at dawn, because our partners in the field collected some census data that said that during the dawn, between 5-6 a.m. is when there is like rush hour, there are more users. So we send on a random day somebody to observe and take a tally count of people entering the community toilet and those that paid the fee, the total fee. So in community toilets, it is really observable who's paying, because it's essentially at the entrance, there is a desk and the caretaker is sitting there, and it's essentially asking people to pay the 5 rupees, which is the market price, the official market price of all of these community toilets. So we can get the share of people that are free riding, that are just entering and are not giving money to the caretaker. And the caretaker has very little enforcement power, and they are really trying to avoid conflict. So if somebody doesn't want to pay, they just enter. That's why there's such high riding. Yes. And so, as I said, the market price is 5 rupees per use. So here on the x-axis, you can see that I'm essentially showing in rupees the market price that people would be willing to pay. And this is the distribution of the share of slum residents by the market price. And what I'm showing here is essentially that the distribution is really skewed towards the left. So people have a very low willingness to pay. In fact, the average willingness to pay is 1.4 rupees, which is only 28% of the official market price. So this is a situation that we find at baseline. And what we also find is that essentially the outside option of people in these slums is because they don't have, most of them don't even have basic sanitation services, is either to use the community toilet or go for open defecation. And we're talking about overcrowded areas of millions of people living in the same city, and people still practicing open defecation, which is really harmful for public health. And what we find at baseline is also that the worse the observed dirtiness of the community toilet, the higher the open defecation. This is just an association, but it can tell us something about how people may not be willing to use these community toilets, to pay for them. They are dirty. They just prefer to go for free on the fields, since they are in really bad, the public service is in really bad quality. So what do we do? So the treatments that we implement are two. So the first one is what we call the supply or the maintenance treatment. And we first offer a one-off city grant scheme, which is equivalent to 90% of the monthly operation and maintenance cost of adequate quality cities. And what we do is we offer the community toilet caretaker to choose between these three grant options. The first one is deep cleaning, the second one is repairs, and the third one is cleaning tools and agents and cleaning training. So this is an example of a deep cleaning. This is how the toilet was looking before on the left-hand side, and on the right-hand side, how it looked after the maintenance, the grant scheme. Examples of repairs of things that are important are locks, mostly for the safety of women, on the gender, on the woman area. So we're fixing locks like this example. Now, why would a treatment as such be important? So releasing resource constraints essentially can improve the regular operation and maintenance, create value, and reduce free riding, akin to escaping the poverty traps that we know from the literature, that big push asset transfers or cash transfers can help people to kind of get on a higher trajectory in terms of their development and their living standards, and are pushing them out of this poverty trap. So we believe that a big push like the city grant scheme can help setting community toilets into a higher trajectory and break this poor maintenance trap. However, external funds in public goods can crowd out private contributions. And we're talking here about a model that is sustained by users' fees. So if users observe that there's an external intervention that is bringing this big push, they may be less willing to contribute to essentially pay the fee. So ex ante, it is ambiguous what we're gonna find from a treatment as such. Now we have the second part of the supply maintenance treatment is providing a financial reward to caretakers. So what we do is that every 2 months, we provide caretakers with the opportunity to receive up to 1/3 of their monthly salary, conditional on keeping the community toilet safe in terms of public health. So that's conditional essentially on us when we come back and we measure randomly on the follow-up surveys that there are soap in all hand washing facilities, that there are no feces in the cubicles, and there is a very, very low bacteria. And what we do is that we pay for this cash incentive every 2 months, and in total, and in the study, there were 4 payments. Now, in the literature, we know that extrinsic rewards such as these can positively affect performance on prosocially motivated tasks. And here the agent, who is the caretaker, is really can be really pro-socially motivated because of the social component of sanitation. But extrinsic rewards as such, as a cash incentive, can also generate unintended consequences. For example, it may crowd out this intrinsic motivation. So it may be that before they were exerting effort just because they know it's important for their community to keep the community toilet clean and run it well. But now they may just do it for the money, meaning that they may exert less effort in other socially desirable outcomes. They can also be facing a multitasking problem. So if we're incentivizing only along these 3 dimensions, they may start doing less of other things, or that are not measured and that they are not going to get paid for doing these other things in terms of the cash incentive. Or they may also engage in a strategic behavior, for example, finding a way around of achieving those outcomes that are not socially desirable. On the second treatment arm, what we do is we complement the maintenance treatment with a sensitization campaign. So essentially, this is treatment from the demand side. So what we do is we visit slum dwellers and we provide information through 4 main components. So the first one is a door-to-door information campaign in which we essentially prepared a leaflet with the help of our partner NGO specialized in sanitation in India, and we tell them about the difficulties of maintaining a community safe and with a good sanitation environment, and how the open defecation can generate externalities, negative externalities on neighbors, because your practice is going to make your neighbors sick. We also talk about the returns to paying the community toilet user fee and the rights and duties when they use the community toilet and when they pay for it. We send monthly reminders in the form of voice messages with key, essentially key information coming from this door-to-door information campaign. We also distribute leaflets so that they can give them to other household members that may have missed the visit in the door-to-door campaign. And we also place posters in community toilets that may remind them of, for example, here, these are the leaflets, and here, this is a poster that is inspired in a Bollywood scene, very famous in India, and people were really remembering this poster placed in the city, talking about the importance and how proud you should feel to have a clean community toilet. Okay, so our approach is essentially randomly allocating to one of these 3 treatment arms 110 catchment areas of the community toilets. So 40 catchment areas were allocated to control group, 35 to maintenance, and 35 to the maintenance plus sensitization treatment arm. The way we sample these catchment areas are as follows. So the unit of randomization is the city and the area around it. That's the catchment area. We identified eligible cities as we first collected a city census of community toilets located in slums in all Lucknow and Kanpur. And then we kept those that are located inside the borders of a slum, that are used by the slum dwellers, located in a residential area, and they are paid to use. And then the catchment area is defined based on the household census data. And essentially what we find is that you can see here that there is a relationship between the distance of the household to the city and their sanitation behavior. So on the left graph, you can see the relationship between the share of people using the city in the census and the distance from the city. And on the right-hand side, you can see the share of practicing open defecation and the distance from the city. And you can see in both cases that there's a sharp decrease in city use and a sharp increase in open defecation that goes up to 200 meters from the community toilet, and then the relationship is a bit flat. So this 250 meters is what we're gonna use essentially to be able to identify the slum residents that are within our catchment area. So the way that we're gonna sample is identify through this slum census any household that is either using the city or practicing open defecation, so a potential user of the community toilet, lives within the city catchment area. And what we do is a two-stage sampling procedure. So what we have here is that this is an example from Lucknow, in which you have a community toilet. You have all the green dots that have access to private toilets, so essentially they are not eligible for the study. And then there are the red dots that do not have access to private toilets, so there are either practicing OD or using the city. And what we do is we first sample from 150 meters away from the community toilet, because distance is really important in how in sanitation behavior, of course. So if we don't get the amount of households for the study in line with our power calculations, we sample from within 250 meters from the community toilet, motivated by the graphs that I showed before, that after 250 meters, there's essentially no change in the sanitation behavior. So we get a sample of households from this catchment area. So the data that we collect is both at the city and slum resident level. So as I said, first, we collect a census of both the city and slum residents. And then we collect panel surveys. We collect a baseline plus 5 follow-ups for the community toilets and 3 follow-ups for the residents. We also collect observations. For example, the one I explained before, about how many users are coming to the community toilet and how many of the users are paying. This is an example of observation. Another observation that we're collecting is stinkiness, dirtiness, if there are feces, if there are black waters inside the community toilet, if the lights are working, if the walls are well painted, if there's soap, if the hygienic facilities are functioning well, the number of functioning toilets, etc., etc. So lots of measurements that will allow us to build infrastructure quality index. And as I said before, also, we collect bacteria swabs that we send to the laboratory to have a good understanding of the health risk. We also conduct several lab in the field experiments, all of them incentivized. So I'm gonna show you first the willingness to pay for CTU, since I already showed you the distribution of it, for you to understand a bit better how we measure that. So what we do is we play the willingness to pay game separately for the most senior men and women in the same household. So we visit them again to try to find them separately so that they don't influence the answer of one or the other. And we are able to have 2 observations per household per gender, so 1 for each gender. And the method that we use is an incentive compatible method called multiple price list that we piloted a lot in the field. The way the multiple price list work is the following. So in this case, we have 13 questions. In each question, there are 2 options that are provided to the participant. Option A is a bundle of 10 tickets to use the community toilet. Essentially, per use, it is 5 rupees. So a bundle of 10 tickets has a market price of 50 rupees. And the other option is varying amount of cash. So first we start with, do you want the bundle of tickets or do you want 0 rupees? Do you want the bundle of tickets or do you want the 5 rupees? And that way they have the option between taking the bundle of tickets or taking the cash, or giving, if they take the bundle of tickets, essentially they are giving up cash. So it's a way of measuring willingness to pay without having to ask them to pay for it, given the context in which we're running this experiment that is of very low living standards. Each question is independent, and we explain them that at the end, there's gonna be a lottery in which 1 ball is gonna come out. Each ball has the same probability. The ball that comes out has a question number, and you get paid the response that you gave in that question. So essentially, if the ball comes out and says 5, and you chose the bundle of ticket in 5, you're gonna get the 10 tickets. If you chose the cash, you're gonna get 20 rupees. So this is an incentivized way, because at the end they're going to be giving up money in each of the questions to be able to accept the bundle of tickets. So the willingness to pay, it's essentially the switching point from between saying, I want the bundle of tickets, to preferring having the money. Now, we also measure demand for public intervention in the community toilets operation and maintenance. And that's important to be able to understand what this willingness to pay is actually capturing, because willingness to pay, it's both my valuation of the community toilet, but also who I think should be paying for it. So what we do is we implement a structured community activity, which is called Voice to the People cards. This is the card that we designed, and it was circulated among our participants as well as their neighbors, and everybody in our study had the chance to mark one key issue in the community that they want to raise to public officials. And this is incentivized because at the end, the results with the distribution of the most important issue is going to be shared with public officials. There's a chance for them to be heard. And the measures, essentially, this is going to be measuring the slum president demand for public intervention, in this case, for if they mark a dirty community toilet to intervene in the community toilet relative to other issues in the community. We also measure through a dictator game intrinsic motivation, both from the caretaker and the slum dweller. And the way dictator games work is that I give you an amount of money and you can donate it back to a sanitation cost, to be able to understand how much you value and how much you have this pro-social intrinsic motivation towards sanitation. And we also run a public good game. I'm not going to get into much about the details right now for the sake of time, but it was to measure social capital and essentially altruistic behavior when you interact with people in your community. We wanted to see if we were moving that, but we don't. But if you want to know a little bit more about the public good game, I'm happy to explain it further. And then we also run a list randomization to be able to measure sanitation behavior, which is a type of sensitive behavior that people will tend to lie about. Because I know open defecation is bad. So if you ask me if I have done it, then I'm not going to say yes. So there's a way in which we can measure this in a better way that I'm going to explain once we get to those results, to not overwhelm you too much with measurements. So now let me give you a timeline of the treatments and data collection. We started in 2017 with a census. Then we go into collecting the baseline at the beginning of 2018. Right after the baseline, for those allocated to the treatment arm of the maintenance plus sensitization, we provide a sensitization campaign. Right after, we start the grant scheme in treated community toilets. Then we go back and we measure again a follow-up one in households and community toilets. And right after that, we provide another sensitization door-to-door campaign. Right after this sensitization, the second one, we in all treatment community toilets, we start the incentive scheme. We first announce it, and then during the following months, we conduct the payment. The payment will be based on each of the measures that we do after the announcement. Payment 1, we go back and we measure. Payment 2, we go back and we measure, and we do it like that. So essentially, we have 5 follow-ups for the community toilet and 3 follow-ups for the household. Essentially, we go back and we conduct surveys in the household, and we play the lab on the field experiments. Throughout the whole year, for those allocated to the sensitization arm, we also provide the voice messages every month. So the methodology is essentially a randomized controlled trial or a field experiment, which it's important to prove, and that's what we have on the paper, that we achieve baseline balance, both in community toilets and slum dwellers characteristics. We also try to keep attrition as low as possible. It is really tricky in these areas in which people tend to go back to their villages, in the rural areas, in some seasons. So what we do when we were finding a higher attrition rate was trying to to keep the sample size in line with our power calculation, we were also using replacements. But all the probability of attrition and of replacement, as you can see in this table, are orthogonal to treatment allocation. So what you can see here is the treatment arms, and here is the probability of being interviewed at baseline, but not being re-interviewed in any follow-up. So we have actually a very low attrition rate. If it's measured like that, we only lose 3% of the sample. But then in each follow-up round, then the attrition rate varies. Between baseline and follow-up 5, so essentially end line, there is a 15% attrition rate, but none of them are correlated, are associated with the treatment allocation. So this is just random in terms of being able to interpret the treatment effects as with a causal interpretation. So we also, in terms of robustness checks, given this attrition, estimate our effects using inverse probability weights. In order to improve precision, we also have estimated all our results with ANCOVA and with double post lasso to select controls at baseline. We also leave some buffer areas between catchment areas, and we find no evidence of spillovers. So actually, I wanted to show you here in the sampling procedure a little bit how the catchment areas of eligible community toilets look like. So each star, this is example of the map of Lucknow. Each star is a community toilet, and each square or polygon is a slum. And now what we do is we randomly allocate each of the community toilets to a treatment arm, control, improvement or maintenance plus the sensitization, and then the supply side improvement or maintenance are the light blue stars. And you can see that stars that are very close to each other are allocated to the same treatment arm, and we're also leaving some buffer areas across treatment arms. Now, overlapping all the eligible households in a slum, this is how it looks like within the slum borders, and then giving our sampling procedure, we're going to be keeping the study sample fairly isolated one from another in terms of the treatment allocation. But we also find no evidence of spillover effects, and what we do is we estimate all our results, stratifying by whether or not the treatment arm was by whether or not the treatment the catchment area was below or above the median distance to another treatment arm, and we find that there's no heterogeneous effect by how close or how far you are from another treatment arm. So our estimation approach then, given that this was a successful randomization, is an OLS, accounting for strata variables and standard errors clustered by catchment area round. So now I'm going to go into the results. And the first one is about breaking the poor quality trap, or breaking the poor maintenance trap. What we find is that during the grant scheme period, the physical maintenance was actually implemented. So it was a successful implementation, and the physical quality of the community toilet was improved. So you can see here the effect on the different outcomes that are measuring maintenance. So first, in the first column is observed physical maintenance of the community toilet. The second column is an index of quality that measures, as I said before, like stinkiness, dirtiness, and the status and the functionality of the community toilet. The third column is an indicator for being above the median of this quality index. And then we have in the column 4, the number of users, and column 5, the share of users free riding. Panel A is bundling both treatment arms, and panel B is separating the treatment arms improvement and improvement plus sensitization treatment arm. And you can see here essentially that on the first column, there's a positive effect, although when we pull all the follow-up rounds, this is not precisely estimated. But what is precisely estimated is a positive effect on the quality of the community toilet, of the infrastructure, the quality of the facility, and also there's a higher probability of being on the higher quality in the distribution of quality by 11 percentage point for a treated community toilet compared to control facility. We also observe that there's no precisely estimated effect in users, although the improvement alone or the maintenance alone treatment arm is decreasing slightly the number of users. I'm going to discuss why that could be, but we're also showing that free riding is decreasing. And what we have here is that pulling all follow-up rounds and both treatment arms, there's a decrease by 8 percentage points. So there's the free riding is lower by 8 percentage points for the treatment arms compared to the control group, which is equivalent to lower free riding by 18% compared to the control mean. And we can see also here comparing the t-test of T1 minus T2 is essentially 0. So there's no differential effect across all treatment rounds between treatment 1 and treatment 2. So it seems that it's mostly driven, all these effects on breaking the poor maintenance trap are basically driven by the supply side intervention rather than the demand side. And as I said before, the physical maintenance is actually observed. The treatment effect is actually observed during the grant period. So you can see here the black coefficient is any treatment, the blue is the maintenance treatment arm, and the red is the maintenance plus sensitization. While in the incentive period, that's not observed anymore. But what is observed in the incentive period is the improvement in quality. So you can see here that the quality, the overall quality of the facility, it's improving during the incentive period, which is exactly when the free riding, the effect on free riding is kicking in, and free riding is decreasing here also in the incentive period. It can be due to an improvement in the quality of the facility. So now people are more likely to actually pay the fee rather than just using it for free. But it can also be because of how caretakers are responding to the interventions and how they are responding to the incentive scheme. So what you can see here is now an effect on the caretaker's behavior. What we're measuring in column 1, the outcome is the number of hours worked by the provider, by the caretaker. 2 is the outcome is the share of the time allocated to management activities, essentially dealing with the manager, collecting the fee or supervising rather than them themselves operating, doing the maintenance and operation of the community toilet. Column 3 is the awareness, is an index of awareness of the caretaker of how important routine maintenance is. And column 4, the number of inputs they use for routine maintenance. And column 5 is essentially a measurement of intrinsic motivation for the cost that was collected with a dictator game. What we can observe is that it's not that caretakers are working more hours, but they're shifting the share of the time that is allocating, that they are allocating to management activities. So essentially now they are much more into collecting the fee. They are also much more aware, in column 3 you can see, much more aware of the importance of routine maintenance, and also they are using more inputs when they are conducting their routine maintenance. And this is observed exactly, both the time allocated to managing and the routine maintenance are observed exactly to be kicking in during the incentive period. So when we're offering the cash incentives, not so much during the grant period. So they are replying, this is a behavioral response to the cash incentives. So we have proven that the maintenance trap can be broken with a big push in the grant scheme, and then it can be sustained and even improve the quality even more by incentivizing providers. However, the providers are responding in different ways. So one is how they allocate their time. that can be socially desirable if it's all about supervising that the community toilet is perfectly clean, but also to collect more of the fees, which can be positive in the sense that then we can achieve financial self-sustainability, but that can also be negative if they are screening out users that are not willing to pay. So with the current financial model that is based on the expected returns from user tariffs, what we do is kind of a back of the envelope calculation that allows us to see how self-sustainable can be this model. And what we find is that the current model plus the supply side treatment could be financed at below the current market rate per use if free riding is completely eradicated. That means that we really need to understand what is driving this decrease in free riding, because it seems to be needed to achieve self-sustainability. So what we do to try to understand this, the determinants of free riding is to decompose the effect on free riding. And this is called the mediation analysis. What I'm showing here in the bars are essentially, this is the effect on free riding estimated during the incentive period, which is a total of a decrease of 9 percentage points. And then the first bar is essentially trying to explain it by the effect on supply side outcomes. The second bar is the effect explained by demand side outcomes. And then the third bar is when we're throwing and trying to explain it by both supply and demand side outcomes. And what we can see in the first bar is that most of the effect on free riding explained by the supply side is due to the maintenance and the quality of the infrastructure, but also on the labor supply of the caretakers. So how they are allocating their time and how they are performing the routine maintenance. So people are more willing to pay for, instead of not paying for the community toilet, are willing to pay for it. People are now paying, both because the facility is better maintained, but also because now they're forcing me more to pay for it, because the caretaker now is more on top of it. What is surprising is that the demand side forces are actually driving free riding to be lower. And we can see here the valuation and the attitudes towards the public good and the awareness of unsafe sanitation and how harmful it can be are actually increasing free riding. So are explaining the effect on free riding, but towards the opposite direction. So what's going on there? Now, the important thing to understand is...
Antonella,
yes?
I'm sorry, I need to remind you about the time constraint.
Yes,
how much
I'm
time do you need?
here.
Okay, perfect, thanks.
Yes.
Sorry to interrupt.
Yes, no worries. So what we're finding here then is trying to understand what is the response from the demand side. From the demand side, we can see that during the grant scheme, there is a temporary crowding out effect of the treatments on the willingness to pay. And what I'm showing here is the inverse demand curve. Between 0 and 1, the inverse demand curve is shifting. So during the grant scheme period, fewer people are willing to pay above 0. But this, then the inverse demand curve here on the right-hand side graph is actually overlapping during the incentive period. So this is just a little bit of evidence of external intervention is crowding out valuation in the short run. But on the long run, actually, what is happening is that there's an increase in the demand for public intervention in the city operation and maintenance of the community toilet. And this increase is equivalent to 50% higher in treatment areas than in the control group. Now, what's happening? Like, we have on the one hand, the fact that we're breaking the poor maintenance trap, but we also know that the users are replying in a different way. So if they are more aware now because of the sensitization campaign that sanitation is important, then they may be more willing to think that there's somebody in the government that should be in charge of that, and that sanitation is more of a right rather than a duty and a good to pay for. So if they go and they force them to pay, if they are not willing to pay, the outside option they have is open defecation. And apparently that's what is happening. So since there's now much more enforcement of paying the fee, the free riding reduces, but at the expense of a higher open defecation in treatment areas. And the way we measure open defecation is with list randomization. So essentially, we have a short and a long list in which we ask people the following question. We randomly allocate people to the short or the long list. The long list incorporates an additional sensitive behavior, which is OD, CTUs, or hand washing. And the response just have to say how many of these things they have done, meaning that on average, the differences between the short and the long list can reveal the share of people that are practicing that sensitive behavior. And what we find is that on average, the treatment arm has almost 20% higher share of people practicing open defecation than the control group. And it results in, unfortunately, a worsening of public health. So we can see that there is an increase in morbidity during the incentive period, and also on the reported health expenditures on the extensive margin. So whether or not people are having curative health expenditures, or people are getting more sick because now there's more open defecation, given that now people that used to go to the community toilet that are not paying the fee are screened out. So in summary, a one-off grant and incentives can effectively break the poor maintenance trap. The reductions in free riding are achieved mostly due to strategic behavior of caretakers. So essentially, they are now enforcing much more the payment of the fee, and this is worsening public health as a consequence. We also find that an external intervention may be crowding out the willingness to pay, the private willingness to contribute to the public good, and this increases the demand for public intervention, which is a challenge for financial viability of a model that relies on user fees. So the main implications of our paper are, first, that in overcrowded and lower income areas, such as slums, where private investments are limited and where health externalities have severe consequences, enforcing financial sustainability may not be socially desirable. And we need to identify how to change certain social norms, for example, that are just making open defecation acceptable, or other constraints that are limiting the behavior change among slum residents in view of improving collective action. And a way to go may be to impose a maximum number of users and understand the effectiveness of monitoring technologies in low coordination environments to ensure that the facilities are preserved and that the fees are paid, but in an amount that is enough to make these facilities self-sustainable at the expense of also keeping the community a safe space in terms of the sanitation and disease environment. So thank you. I look forward to all your comments and questions.
Very good. Thanks very much, Antonella. The floor is open to questions. There is a good number of issues raised in this paper. The topic is a bit unusual, but we all agree very important. And lots and lots of aspects covered. Please, the floor is open.
May I start?
Please, Bernardo.
Well, thanks, Antonella, for the presentation. Well, my first question, I think like at least you touched on this at the end. So at some point you mentioned that it was possible to make this like financially sustainable by completely eliminating free riding. And then while you show that even though there is a decrease in free riding, part of it is because like these people are actually relying on open defecation. So my question is like, when you talk about like eliminating free riding to make it financially sustainable, do you mean like that basically like all the users will pay? I mean, like, let's say if before enforcement there were like 100 people using it, do you mean that the 100 people keep going and now pay? Or do you mean that still like maybe 80 will come and pay and then 20 can go out? Like what are the numbers for this to be sustainable?
Yes, no, that's a great question. So actually our back of the envelope calculation suggests that for an adequate level of CT in terms of how much it costs to run it, plus supply side treatment as the one that we have performed, there would be a need to completely eradicate free riding, meaning that is a matter of changing two things. One is changing social norms, that make people think that sanitation is a right and they don't want to pay,
Mhm.
but also taking care of those that are not able to pay. An ability to pay is something that could be, for example, dealt with if we provide some cash transfers that are conditional on using sanitation facilities or some targeted subsidies. But of course, targeting is is a challenging exercise.
Mhm.
What we do find is that for an average household of 5 household members that are using the community toilet once for every day, the equivalent of the expenditure on these community toilets would be of, so essentially that is 8% of their household income,
Yeah.
which is exactly the same that they are on average spending on intoxicants, on alcohol, on cigarettes, on tobacco. So it seems to be the case that is more like not wanting to pay than not being able to. So that's why it's so important to change the social norms. That right now, all the message of Modi and all over India to make India open defecation free is mostly about the right to have access to sanitation, and not much about the duties to pay for these public goods. So yeah, there's a lot to discuss there in terms of whether public goods should be purely free or not, and there's a large debate that we're trying to contribute to. But what I can say is also that at baseline, lots of the community toilets that were provided fully for free and fully
Yeah.
subsidized by the government were in really bad conditions. Because we're talking about governments that even if they fully subsidize them, they don't have the capacity to maintain good public infrastructure and basic services. So that's a big trade-off.
Yeah, no, I totally understand. And even in a developed country like the UK, sometimes when you use public toilets, they are not in the best condition to say, like those which are free. So,
Okay, Bernardo, you have
yeah,
another
so
question?
one more
Please.
question.
Yeah, sure.
Do you look at any information about heterogeneity about like those, I don't know, for example, like those who keep free riding, or like, or those to switch from free riding to open defecation, or in general about users?
Yes, I couldn't discuss much about heterogeneity, but to be honest, we find that these effects are fairly homogeneous. So we run a battery of analysis on heterogeneous effects from everything we had in the pre-analysis plan to running a causal forest model. And the effects are quite homogeneous, to be honest. Here and there are some heterogeneities, but when we perform multiple hypothesis testing, they don't survive, which it was surprising. We thought that we may find like really big heterogeneous impacts, like from the dimensions that you have mentioned now.
Thank you. All right. Any further questions, please? Questions, comments? Any suggestions? While people are thinking, I have a couple of them, Antonella. The first one, in public-private partnership, one of the key topics is not necessarily the incentives of people to contribute, what you call free riding, but the incentives of the provider to provide a quality product. And in the literature about outsourcing of social services, that's the key topic. What are the incentives of a private contractor to do a good job? And especially when quality is hard to observe, so on and so forth. You touched this issue somewhat, but not a great deal. So maybe you can expand on this, because poor conditions of these facilities might be not only because people are unwilling to pay, but also because the incentives are not there. So it's just kind of a cash cow. Demand is solid, and if the enforcement becomes stronger, then I guess, and especially if people are spending more time on collecting fees than on cleaning and doing stuff, that might be a bit of a conflict of interest in how that is resolved. And the second issue that you touched in passing is, and that was actually something that I was thinking about, is this indeed a right and not, a privilege to use these facilities? And different countries answer this question differently. In North America, almost all public toilets are free for the public, and there are no fees. In Europe, usually people are required to pay. And I think Russia follows the European tradition. Do you have any recommendations? Would it be better for a country such as India to make it publicly available so the government pays and the government controls quality? So what can you say about this?
Yes, no, thank you very much for your comments. On the incentives of the private contractor, indeed, you're right that this is a really important aspect, and that's what motivated our improvement treatment arm when we were doing visits in the field and observing how the providers are acting. And a lot of these providers are just exerting the minimum effort. And that's why we thought that a cash transfer can incentivize the behavior that we actually want to, which is a good and clean toilet. But the problem with this that is highlighted in the literature with these type of incentives is that they may engage in strategic behavior, and partially they are, since they are more aware and they are using more inputs for the maintenance and they're supervising more the cleaner, but they are moving away from them themselves doing the job. So they are becoming more of a principal than an agent. And they're engaging strategic behavior by essentially collecting more of the fee because they know that's going to give them more resources to keep the toilet clean. If that's socially desirable, it may be, because more resources make you be able to sustain a better quality of infrastructure, but not at the expense of people, that backfiring to the extent that people are forced to rely on unsafe behavior. I think there's a lot of scope to do much more research on this and trying to understand the providers' behavioral responses. And then on the second part there's this very big debate on whether basic public services like a public toilet should be for free or not. In like I was telling before to Bernardo, in the case of India, there are some toilets that are fully subsidized. Doesn't mean that they are in good quality. If anything, they were even in worse conditions. So it's a bit of trying to understand the institutional capacity of the government to be able to run fully subsidized public services, which is not always the case. So it's a complicated issue, an important one, and I think, yeah, indeed, in that sense, more research in other facilities are needed to get a full picture. But here we're trying to provide kind of a first evidence of an important context in India.
Okay, thanks. I would like to make a quick comment about the literature in the philanthropy fundraising, in the private donation literature. There are some papers which show the importance of leadership grants. Mm-hmm. If you collect contributions to fund the public good, then in equilibrium, the collection might be quite low. But if there is a critical mass contributed by government or by a grant leader, big donor, then the follow-up collection is facilitated and expedited. And you might want to have a look at that literature, and of course, if you haven't done it yet. James Andrioni is the guy who did lots of work on that. If you need any details, let me know. I will send you a couple of references.
Thank you very much.
For your paper. Okay.
Sorry, I have one more quick question.
Bernardo, please.
I mean, I don't know if it's feasible, so, but I was wondering, so you get some information on the willingness to pay of individuals. From that information, is it possible to infer whether the pricing strategy is optimal, or if with a different price they could achieve better results?
Yeah, that's a good point in terms of optimal pricing. We received comments in the past of optimal contracts, optimal pricing. I don't know, do you have any idea in mind? Because we have discussed a few times, and then we're not sure we can do it with our data, but maybe you have a good idea of how this can be done.
No, not at the moment. It just came to my mind right now. I don't have any concrete suggestions. Just was in principle, if you think that it's feasible to do something or
Yeah, the
not.
thing is that there's no variation on the actual market price to be able to see which would be like the optimal pricing in terms of the relationship with that and the quality. It's much more about this kind of hypothetical scenarios that we're
Yeah.
giving people. If we would have variation in price across community toilets, which is pretty standard here, is 5 rupees, we could, the variation we have is on whether or not they pay for the fee, not how much they pay for it.
Okay.
Yeah, if we would have how much people pay for it, then yeah, we could, I think, do this pricing exercise.
Okay, thanks.
Very good. Thanks. Let's see if there are any further questions, comments, clarifications. I don't see any, which means that we have to thank Antonella for the thought-provoking presentation. And Bernardo, conventionally, we're going to meet less frequently this season. It will be on the average one seminar every 2 weeks, not 1 week as before. So we give preferences to quality over quantity. Bernardo, can you make an announcement of what to expect?
Yes. So, well, and actually the next seminar is in exactly 2 weeks. So on Thursday, 7th October. And we will have Joshua Goodman from Boston University, and he's going to present the COVID-19 pandemic disrupted both school bullying and cyberbullying. So
okay,
going to be the next.
Great lineup. We had him in San Andreas not that long ago.
Okay.
Very interesting intervention.
Okay.
very good. Okay.
Well, Antonella, I think you got some comment in the chat that you may want to have a look.
Oh, Elena, right. 2-bit scheme to.
Great. It's a suggestion.
Yeah, this is from Elena.
To be.
Elena, Antonella, do you want to expand on this, or you can communicate privately, perhaps, if need be?
If there's time, I would love to hear the idea.
Okay. Well, maybe my suggestion would be that you guys stay in touch directly, exchange emails and follow on this. And as I promised, I will send to Antonella a reference to this paper on leadership grants. So hopefully not only us will learn something from this presentation, but you get some useful feedback as well.
Perfect.
Okay. I'd like to wish everyone a good evening. To Antonella, it's going to be a good day, I guess, right? What time is? Oh, no, you're in the UK.
I'm not too far away.
For some reasons, I was under the impression that you're either in Latin America or in India, but you're in England,
I'm in the UK. Yes.
All right. Okay. So then,
Scotland, so.
Good evening, more or less on the same way. Antonella, have a good evening.
Thank you so much.
Dear colleagues, we'll see each other in 2 weeks. Bye.